Hi, everyone. My name is Jordan Goodrich. I'm a physician at the Sherborne Health Center. So I created this video for learners with us in order to provide them with some information about some of the first-line antiretroviral regimens that we use to treat chronic HIV infection, as it's something that we often don't get too much training in medical school about. As a note, we get more and more treatments every year, and new combinations often come out, as well as new studies supporting different combinations. So it's important to try to stay as up to date as you can about what the first line regimens are. I'll try to use the comment section in the video description in order to post updates to the first line regimens. So this presentation will talk about things that are current as of February 2020, but then for any updates, I do encourage you to look at the description of the video. As a note, this presentation primarily focuses on the first line treatment options for the patient who is, let's say, either newly diagnosed with HIV or is newly starting antiretrovirals. And those individuals we call ARV naive. So they're generally viremic, which means they have a detectable viral load, usually in the hundreds, thousands, and are opting for treatment now. The treatments I talk about today are also good options for most patients who are switching from another regimen. Of course, there are exceptions, such as if an individual has resistance to a component in one of these regimens. That being said, this presentation does not go over resistance or other aspects of HIV care in much detail, but I would encourage you to seek out this information if it is an area of interest for you. And generally, any patient can and usually should start ARVs, both to prevent transmission to partners and to maintain someone's immune system. Generally, the sooner you start antiretrovirals, the higher their CD4 count, and therefore the higher their immune system function. The medications that we have now are very well tolerated. So compared to some of the treatments that we used before, we really don't worry about toxicities in the long term for the most part. Family physicians can even start antiretroviral treatment and discuss side effects and interactions with their patients. Historically, this has mostly been done by infectious disease doctors, but we know that there are a few really good regimens that most patients can be started on. And listed here are the important 3 drug regimens that I'd say to know. The first being first line treatment regimens for the antiretroviral naive patient that also have high barriers to resistance. And what that means is it's difficult for the HIV virus to develop resistance to these drugs, even in individuals who may have difficulty taking the medication every single day. So there are 4 first line treatment regimens. I've listed 3, the first of which is called Biktarvy, a 1 pill once a day regimen that includes these 3 components, which I'll go into in future slides. Bictegravir, the newer form of tenofovir called TAF, and emtricitabine. You'll notice that we use 3 drugs for most patients, and I'll explain what mechanisms we use and why in the future slide. Um, the next first line treatment with a high barrier to resistance that is worthwhile knowing is called Triumec. It has a very similar drug called dolutegravir, also has a high barrier to resistance, plus a 2-drug backbone, this time with abacavir and lamivudine. I'll talk about important things to know about that. Tivicay, which is dolutegravir on its own, plus a backbone is the other really good option. One of the downsides of this regimen is that it's 2 pills once a day rather than 1 pill once a day. But there are certain situations where it might be chosen over other regimens. Biktarvy, Triumec, Tivicay, Truvada, and Descovy are some of the most important ones, I'd say, to remember and to know the components of. But other drugs that are worth being familiar with, generally because they've been used quite often in the past, you'll likely see a lot of patients who are still on them from previously. Usually, you can keep patients on them as long as they're tolerating the medication quite well, but that you might want to switch them off of in certain situations include the following. Genvoya, or the older form called Stribild, and the newer form versus the older form have the same components except the tenofovir is the newer form in Genvoya and the older form in Stribild. And I'll talk about why that's or why that's important. So generally we go with the newer form of tenofovir, and I'll explain that in future slides. Odefsey or Complera, again with a newer or older form of tenofovir. Atripla, which is an important one to know. It was the first single tab regimen, so a lot of patients were put on that early on, but the efavirenz in it can cause quite a number of CNS side effects, like vivid dreams, insomnia, dizziness, etc. So it is something that if your patients aren't tolerating well, it might be worth switching them off. Of note, it's the only single tablet regimen that currently has a generic out. And remember, every time I say single tablet regimen, I mean a one pill, once a day option that has all of the antiretrovirals that's needed to keep a person's viral load suppressed. The last one I'd say is really important to know is darunavir, um, which is a protease inhibitor, and I'll talk about what that is on the next slide. Um, that's boosted by another drug, plus then again has a backbone. So I laid this all out because when you look through the slide, you can see some similarities between the first line treatments, which I'll talk about later, in terms of the first drug that's listed, as well as one of two backbones, either being a combination of tenofovir and emtricitabine, or a combination of abacavir and lamivudine. So while a lot of people get overwhelmed, feeling like there's so many different drugs and options in HIV care, when you simplify it like that, you realize that we're using most of the same drugs these days in different combinations. And so having a bit of knowledge about some of the drugs that compose these single tablet regimens can be quite helpful. So I won't go into too much detail with this slide, which shows how the HIV virus replicates using the CD4 cell that it infects. What's important to know is that we use this knowledge in order to treat HIV and to suppress the virus. Generally, what we do is we treat HIV with at least three drugs from at least two different classes, or in other words, with at least two different mechanisms of action. All of the first line regimens include two NRTIs, which are nucleotide nucleoside reverse transcriptase inhibitors, as well as one integrase inhibitor, or INSTI. The NRTIs prevent the HIV RNA from being turned into DNA by the reverse transcriptase enzyme. And how it does it is that the drug acts like the building block of a DNA strand and then terminates that strand once it gets incorporated. The integrase inhibitors work by preventing the DNA that's formed from being integrated into the host CD4 cell's genome. As you can see here, the initial treatment regimens that are preferred generally consist of an integrase inhibitor plus a backbone of two NRTIs, which are nucleoside-nucleotide reverse transcriptase inhibitors. As noted on the previous slide, these include Biktarvy or Triumeq, or as a less desirable option, two pills, such as dolutegravir in the form of Tivicay, and either Descovy or Truvada, the latter of which has a generic out and is covered under the ODB formulary at the moment, unlike Descovy. Now, this was just updated in December 2019, and I encourage you to check the comments section of this video to see if there are other updates, because the first line regimens are being updated quite regularly with new treatments becoming available. One of the big changes is that now there is a drug that, a pill that contains an integrase inhibitor plus only one NRTI that has been found to be as effective as an integrase inhibitor plus two NRTI combination. The brand name of this medication is Dovato, and as you can see, it's essentially Triumeq without the abacavir. So the benefit of this treatment is that it has a high barrier to resistance with dolutegravir. It has lamivudine, but it doesn't have abacavir, and therefore you don't need the HLA-B5701 test. That test is crucial to get on anyone who is being started on abacavir or considered for this treatment, because if an individual is HLA-B5701 positive, then they're at high risk for a certain type of reaction that is very similar to Stevens-Johnson syndrome, an abacavir hypersensitivity reaction. And that's one of the key takeaways I want you to know from this slide. We generally get the HLA-B5701 test at baseline, so that if in the future we want to consider abacavir, we know whether it could be considered in this patient. It's crucial to get on anybody. The benefit of Dovato is it only contains two drugs, so overall it may have a lower risk of long-term toxicities, but there are certain populations that cannot take this drug. So it's only advised at the moment if the individual's baseline RNA or viral load is less than 500,000, if there's no Hep B co-infection, and as long as the genotype, which is a resistance testing, is back and shows no resistance to either component of dolutegravir or lamivudine. We'd also want the Hep B test to be back and to be negative. To demonstrate what these drugs look like, I created a slideshow showing that this NRTI backbone can come in the form of Descovy or, when combined with bictegravir, is a drug called Biktarvy. It's a small, easy to take pill that only as of the end of July 2019 is now covered under the ODB, Ontario Drug Benefit Program, which means it is covered under ODSP, it is covered under the Seniors Plan, under OHIP Plus, as well as other provincial drug programs like Trillium in Ontario works. Another medication that is covered under ODB is Triumec, which contains dolutegravir as the integrase inhibitor, abacavir, and lamivudine. Again, it's important to test an individual for HLA-B5701 and have a negative result before starting someone on this regimen. And that prevents hypersensitivity in the vast majority of cases. This is one of the main things that differentiates it from Biktarvy, which can be started without the HLA-B5701 test, but otherwise is similar in terms of potency, in terms of a high barrier to resistance, and has really good long-term clinical data behind it to support its use. And as a reminder, without abacavir, there's a pill that comes with dolutegravir and lamivudine called Dovato. It's a two-drug regimen that can be used in a number of different patients, but is restricted to those with a viral load less than 500,000, and where you need the other preliminary testing back to ensure that there's no resistance to either component in this regimen and that they're Hep B negative. The third of the first-line treatment regimens is that two-pill regimen that I told you about, either Truvada or Descovy plus Tivicay. Tivicay or dolutegravir is available in a pill on its own, and then you'd give it with one of these backbone options. Unfortunately, Descovy is not right now ODB covered, but it does have the newer form of tenofovir called TAF. The unfortunate part is Truvada, which you may have heard about because it's the drug that we use for HIV PrEP or pre-exposure prophylaxis, a medication that we use in certain high-risk groups, such as men who have sex with men with inconsistent condom use and multiple sexual partners, or individuals who inject drugs and share drug paraphernalia. These individuals can be started on a two-drug regimen with Truvada, and daily use can prevent transmission. What we know about Truvada is it has the old form of tenofovir called TDF, and this can have some bone and renal toxicity, putting someone at risk for osteoporosis with long-term use, and potentially in a percentage of individuals causing problems with the kidneys. The kidney function is something that is closely monitored, but something to be absolutely aware of. So either Descovy or Truvada plus Tivicay is the third treatment option. It's a great option, acknowledging that it takes two pills once a day rather than one pill once a day, like the other options that I've discussed. Another note is that when Truvada and Tivicay are used together, they can be used as a post-exposure prophylaxis or a PEP regimen, which is a 28-day course of those HIV drugs used to prevent HIV acquisition in an HIV negative person who has had a recent potential exposure, whether that be an occupational exposure or a non-occupational exposure, such as through sexual exposure or sharing needles or other routes that are deemed high risk. Something that makes a lot of providers really anxious are the potential side effect of antiretrovirals. And in reality, the newer drugs that are significantly better tolerated and less toxic actually cause far fewer side effects. They tend to be similar to the side effects of any drug. For example, gastrointestinal side effects like nausea, vomiting, and diarrhea, central nervous type side effects like headache, either insomnia or fatigue, dizziness, etc. Some of them can cause a rash. Minor rashes tend to go away quickly with time, though hypersensitivity reactions can also happen, as mentioned before, especially to certain HIV medications like abacavir. It's important that these side effects are discussed with clients prior to starting so that they can assess for them, but you can reassure them that the vast majority of side effects from antiretrovirals will tend to resolve within 2 to 4 weeks of ongoing use. Now we'll talk about specific antiretroviral regimens that were discussed in previous slides, as well as their side effects. First off, there's Biktarvy, which tends to be well tolerated overall. Side effects generally affect about less than 1 in 10 people. And there are few interactions with Biktarvy, but all integrase inhibitors, including the bictegravir in Biktarvy, as well as dolutegravir in our other first-line options, interact with polyvalent cations. This is the most important interaction to be aware of with integrase inhibitors. These cations can chelate the integrase inhibitors in the gut, preventing their absorption and putting someone at risk for subtherapeutic drug levels, which may result in the development of HIV resistance. It's important to counsel patients that these cations exist in many over-the-counter drugs, such as Tums and iron pills. And if you refer to the drug monographs, they outline how long these antiretroviral drugs must be spaced out from polyvalent cations in order to prevent chelation. Generally, it's at least 2 hours apart. Otherwise, there are actually few other significant drug interactions. It's always wise to use a drug interaction checker to ensure that no significant interactions will take place, but this will be discussed in a future slide. Triumeq, which contains dolutegravir plus abacavir and lamivudine, is very well tolerated. Recent studies have seen varying levels of weight gain in some individuals using dolutegravir, so it's important to counsel patients on that. But remember again, probably the most important thing with abacavir is its risk of hypersensitivity, which is why it's important to do the HLA B5701 testing in advance of using it. Additionally, abacavir has been linked to a slightly increased risk of ischemic heart disease, including MI, so we avoid it in patients with other cardiovascular risk factors. Otherwise, the drug effects, side effects of dolutegravir, abacavir, and lamivudine in Triumeq tends to be typical of most drugs that we prescribe our patients. Because of the integrase inhibitor in dolutegravir, don't forget about the interaction with polyvalent cations, which you should be counseling patients on. It's wise in general to just avoid the use of these polyvalent cations wherever possible, but if not, to space them out, as we talked about previously. Interestingly, with dolutegravir, unlike the other integrase inhibitors, we see an increase in metformin levels by 2 times. So you therefore adjust metformin levels accordingly, and most experts recommend using a max of 1 gram of metformin over the period of a day if the patient is taking dolutegravir. What you'll notice for the most part, is that the NRTI backbone does not interact with other medications, and that it's usually the non-NRTI component of an ARV regimen, such as the integrase inhibitor in this case, that interacts with other medications. Not surprisingly, the side effect profile of Dovato is similar to Triumeq, but because it does not include abacavir, it lacks the concerns about hypersensitivity in those who are HLA positive. It also does not have the same concern regarding ischemic heart disease risk. And again, recall it's not the backbone, but rather the dolutegravir in this case that causes the drug interactions with Dovato. So essentially, you'll see here the drug interactions are the same as they are with Triumeq. And then lastly, the first line regimens, remember that there's the dolutegravir plus the pill that contains tenofovir and emtricitabine. Emtricitabine is one of the most common culprits for a rash, but generally will go away over time. So if a patient is doing okay, they're having a little bit of mild discomfort, but would like to continue the regimen, it's very safe to do so. Remember, if there's a newer form of tenofovir, it's Descovy, which is currently not ODB covered. And if it's the older form of tenofovir, TDF, it will be Truvada. So Descovy, the newer form of tenofovir, TAF, really doesn't have very many significant side effects, as you can see from the slide. With Truvada, we worry about the bone and the kidney effects. In terms of interactions, it's the same as we've already discussed because of the dolutegravir component. Now, I do want to talk about some other treatments that you'd use in certain situations. Here you can see Genvoya or Stribild, depending on whether there is the new form of tenofovir or the old form of tenofovir. You can see that a lot of this is getting repetitive, and that's because we use some of the same medications in the different regimens. This is a very well-known medication. It's been tried, it's been used for a number of years now. It was the first complete one pill, once a day regimen that was integrase inhibitor based, Stribild. So a lot of patients you encounter might still be on it. And it's worth knowing that unlike Biktarvy and Triumeq, Genvoya and Stribild do have a large number of drug interactions. That being said, it's a very well tolerated drug on its own. There's not a lot of side effects unless you're using the older form. So the newer form, Genvoya, really well tolerated. The older form, Stribild, that has TDF, has that bone and kidney disease risk. And overall, because it has the elbapygravir, there is that risk of chelation. But because there's a booster in this drug, so if you look to the right of elbapygravir, you'll see a CO for cobicistat. That's a medication that prevents the degradation of elbapygravir by liver enzymes. But by inactivating some of these liver enzymes temporarily, it unfortunately can also boost the levels of a number of other different drugs, causing many, many different drug interactions to exist. And I'll show you where you can look in order to see what level these interactions happen at and what adjustments you might have to make as a result. The other one that I thought was worth bringing up was the boosted protease inhibitor that's used in combination with one of these backbones. Darunavir is really the only protease inhibitor that is started now on patients compared to the other older protease inhibitors. And we still like it for some individuals, especially those who have poor adherence to medications, who might have developed resistance to other drugs, because we know that boosted darunavir has the highest barrier to resistance compared to any other single HIV drug. Now, there are different ways that we can boost it, and remember, to boost it, we block some of the enzymes that are working in the liver to help increase the levels of the drug that we want a higher amount of, or that we want to exist in the body for a longer period of time. Here I show ritonavir, which has been out for a number of years now and has commonly been used. The thing about protease inhibitors as a class is they do have a high risk of side effects, such as dyslipidemia, hyperglycemia, and GI intolerance. Important to know is because all of the protease inhibitors have to be boosted, they have tons of interactions through a variety of different enzymes. In this case, ritonavir inhibits certain enzymes to boost the darunavir, but also induces certain enzymes, which can lower the concentration of other drugs. So it's very important that if an individual is on a regimen like this, you use the interaction checkers in order to adjust other medications accordingly, or to choose which medications might be best for your patient, for instance, if starting a statin or an antihypertensive. Now, there is a slightly newer drug that combines darunavir with the booster in it, and that is called Prescribix. Likely has similar side effects, but has an ease of use in that there's fewer pills. You just take Prescribix plus either Truvada or Descovy once a day. Unfortunately, there are still a lot of drug interactions. Cobicistat works a little bit different. It inhibits and boosts levels, doesn't really induce though. The reason that's important is that if you want to simplify a patient from darunavir plus ritonavir to darunavir plus cobicistat or Prescribix, you have to keep in mind that their effects on liver enzymes might be different, and you might have to change the drug level or the dosages of other medications that you use. So that was me fast tracking through really the most important antiretrovirals I would say that we use day to day at the moment. It's important to be aware of the interactions, like we talked about with absorption, that happens with chelation. Other drugs need an acidic stomach environment. For instance, rilpivirine, which is an Odefsey, as well as Complera, need acid to be absorbed. There are different cytokine P450 mechanisms of interactions, specifically working through the liver, that it's important to be aware of. And there are other mechanisms, like with dolutegravir, increasing metformin levels. There are great resources out there that are specific to HIV treatment. For instance, the HIVclinic.ca website has some great tables that are useful if you're looking to start someone on a particular class of medication and want to choose a drug with fewest interactions with the HIV regimen they're on. When there are potential for interactions, they sometimes outline how to adjust the dosage of the drug to account for this. Here's an example with various statins. If you run down that first column, you can see most of the commonly used integrase inhibitors, including bictegravir in Biktarvy and dolutegravir, like in Tivicay and Triumeq, don't interact with any statin. This means you can start the individual on any statin without worrying about drug interactions. However, following the next column down, you can see that there are more interactions with boosted elvitegravir, as in Genvoya and Strivold. The booster cobicistat is responsible for this. Similar trends occur with boosted protease inhibitors, as in the last column. Dose adjustments and close monitoring would be recommended for these drugs. And I always like to say that it's important to use two different interaction checkers just to double check your work, because there are some discrepancies in the different systems that are used. This is a great resource out by Liverpool, hiv-druginteractions.org, where you can type in the various medications an individual is on, and it will tell you about interactions between the drugs and how you might want to adjust accordingly. So here you can see it's found a potential interaction between dolutegravir and metformin. As mentioned before, this is something that is one of the interactions you should be aware of with dolutegravir. As you can see here, it even gives a suggestion of limiting the total daily dose of metformin to 1 gram total in the day. And the guidelines, which are very long and extensive, have a lot of information about interactions as well. The last thing I'm going to talk about in this presentation is the importance of being aware of the cost of these medications. Other than generic Atripla, all of the one pill once a day regimens are only brand name and cost at least $1,100 per month. So it's important that these individuals have drug coverage. If they don't, it's important either that they access private drug coverage through work or elsewhere, or apply for one of the government public funding programs for drug coverage, like Trillium, which everyone is eligible for, or the ODB program through Ontario Works, ODSP, seniors who are 65 or above, or OHIP Plus if they're 24 and below. Now, seniors plan and OHIP Plus, they're automatically registered into. The other ones they need to apply for. It's important to know for Trillium that in order to really benefit from it, your prescription drug costs have to be at least about 4% of your net household income. The reason being is that an individual has to pay a deductible of about 4% of their net household income, and then Trillium kicks in and will pay for 100% of the remaining prescription drugs. Now, 4% of the net household income can be quite a steep price. So luckily, the drug companies have acknowledged this and have created these payment support programs that can be accessed either by contacting a representative from the drug company or by sending a patient to a pharmacy that has these support program cards available, such as pharmacy.ca here in Toronto. Other things with a new diagnosis and with starting someone on antiretrovirals to let them know is that they can expect a near normal life expectancy, that that isn't the end for them, and that HIV, while still very stigmatized, is starting to become something that is more and more talked about, and that there is more awareness that treatment is really prevention. There's a movement called U equals U that means that if an individual is U, undetectable for at least 6 months, and taking their antiretrovirals daily, then the virus is U, untransmittable. This is specific for sexual intercourse, where it's been demonstrated in large studies in the past, but has not yet been demonstrated in other studies, like sharing intravenous drugs, for instance, largely because it just hasn't been studied. An important thing, though, is that non-disclosure to a sexual partner can be deemed a criminal offense in certain circumstances. And if the patient lives in Toronto, they can access HALCO, the HIV/AIDS legal community organization, to get legal advice about this issue. But this generally applies to those individuals who are viremic, if there's an issue like not using a condom or a condom breaks, things like that. But some of this information is available online. And lastly, I like to talk to my patients a little bit about what their partners might be able to do, especially before the period where they're undetectable for 6 months. So of course, there's treatment as prevention, which is the undetectable equals untransmittable movement. But sexual partners can lower their own risk by being on PrEP, pre-exposure prophylaxis. And again, that's the Truvada daily tablet that they can take. PEP, which means that if there is something like a condom breakage, they can access the 28 days of medications as long as they start within 72 hours of the potential exposure. Condom use, of course, avoiding sharing needles and other drug paraphernalia, etc. Thank you for taking the time to listen to this presentation. Hope it's answered some of your questions about HIV care.